Okay, welcome everybody. Welcome to the January 2026 England and Wales ITP patients meeting. With us today, we've got Professor Adrian Newland, who's the Chair of Trustees of the ITP Board Association, and myself. I work with the association. My name is Mervyn Morgan. If you've got any questions, please just put your hand up or just join in with your question. Hope you got any new people today on the call? You have,
Well,
right?
that's good. That's excellent.
Excellent. Welcome, Gina. Anyone else? Anyone else new? Oh, Catherine, Glenn, good stuff.
Ian, yeah.
So, great stuff. Hello, Rhonda. We've also got Rhonda Anderson here. Rhonda is a patient observer on our board and also one of our mentors. Probably she won't like me saying it, a senior mentor, but I've said it now.
She's only senior because she's been here a very long time, nothing else at all.
Not
Great
senile,
stuff.
not senile, not yet.
Not yet, no, not yet. Far from it, far from it. Right. Does anyone want to go first with some questions? Who wants the first question? Any of the new people? Glenn, you're muted, sir. So if you just unmute. Down the bottom left. That's it.
I found the button. Thank you very much indeed. I've got two questions, hopefully not too involved. Just by way of my background, I was diagnosed with ITP in 2010 from a routine blood test. I had 5 years of just annual monitoring. Then my platelets in 2015 dropped to 1, and I undertook some intensive medication, things like, started on prednisolone, rituximab, and then IVIG. That seemed to help boost my numbers, and I've been on annual monitoring ever since, with my numbers typically being over 50. So I've been quite stable. The last 3 years, my platelets have been in the normal range, over 150. So two questions really, but the first one was, can you ever regard yourself as in remission from ITP? And at what point do you start not having to tell travel insurance companies, because I'm of an age now I'm able to travel, and being retired? And the second one is my GP, a couple of years ago, suddenly announced that they think that my ITP was triggered by a reaction to the cholesterol drugs I was on at the time. Is that now regarded as a possible cause for some ITPs? So two questions: can you ever be in remission? And the other question is, can ITP be triggered by cholesterol medication?
Yeah, but both interesting points. I'd start off by saying it's interesting that you were picked up just by an incidental blood test, because I guess about a third of people with ITP are picked up incidentally. They have no problems, and if they hadn't had a blood test for you, going into hospital for minor surgery or having a routine blood test done, they would never have been picked up. And you may have presented later, say 5 years later, when your count dropped, if you'd got bruising. So you'd have suddenly then appeared as an acute ITP, whereas in fact you had a chronic ITP. In the majority of adults who are the ones that tend to have chronic ITP, a small number do go into remission and remain in remission, and the disease never comes back. But there is always a potential that it come back if triggered. And I suspect after 5 years, when your platelet count dropped, there was some challenge, maybe a virus infection, or you'd taken a different tablet, or maybe you had even eaten something with a chemical in that you reacted to. And we often find that the platelets drop, then you need a short course of treatment, the count goes up again and then remains up for a prolonged period. Now, the question is whether you're ever cured is a very difficult one, because it's a sort of comment you can make after the event, if you see what I mean. If the disease never comes back, you're cured. What I would say though, with regard to the insurance companies, if you've been off treatment now for, I don't know, many years,
Nearly 10 years now, yeah.
10 years, and have not had treatment, you can quite rightly say to them that I had this diagnosis in the past. I've been completely free of all disease for 10 years. And to all intents and purposes, yes, you probably are cured if your count is running within the normal range. And that's how I'd phrase it. You can't necessarily mask the fact that you...
Can I just say, it's only been in the normal range over the last 3 years.
Well, because I can't say that if you were challenged again, maybe a vaccination, maybe a virus infection, that your count may not fall because you have that propensity. But by all definitions, yes, you are cured. But I could never categorically say 100% this will not come back. With regard whether this is related to the statins, I think, to be honest, it's highly unlikely, mainly because statins are now very widely used. I mean, millions of people take statins, and it is not something that's been widely recognized when you're on statins. It's a question of sort of cause and effect, or association and cause. The fact that some people develop a low count when on a drug, if you start a drug and your count goes down, then there's a clear association. If you stop the drug and the count goes up, then it's the cause of it. And there are a lot of drugs that cause platelet counts to fall. If you've been on a drug and your count falls, it's unlikely to be often. If you've been on the drug for a long time, and if you continue to take the drug and your count responds and stays up, then it's very unlikely to be related to that. And I think there is no convincing evidence at all that statins cause thrombocytopenia.
Interesting. Particularly as my cholesterol is gone up, and my GP is thinking that do we leave it because of her belief that the ITP was triggered by previous statins. But maybe I need to go back and have another conversation with her, which is why this kind of discussion, to be able to talk to an expert like yourself, is really helpful.
There is no significant association of thrombocytopenia with statins.
Thank you.
But a lot of people do react to odd drugs if you Google it. I mean, there's some drugs that quite commonly and are regularly associated. Whether anyone has an idiosyncratic association, but if you've been on a drug for a long time and your platelet count falls, it's very unlikely to be related to that drug.
Okay, that's really helpful. Thank you very much.
Thank you.
I know other people up there, they're more difficult questions now.
Rhonda, you got your hand up.
Yes, I just wanted to add to some of that. I mean, I'm not a medically trained person. I cannot give medical advice. But since Adrian is here, he will correct me if I'm wrong, or tell me that not to say any more. I have been in long-term remission from ITP since 2000. Because I had a splenectomy. Now, splenectomy is not normally done these days, but that did, in fact, eventually get my platelet count up into normal levels after lots of steroids and other medication as well. However, as I understand it, the platelets that go through the spleen are filtered out because they are covered in an antibody. So even if your platelet count goes up, your immune system is still working, and some of the platelets or all of the platelets will be covered in the antibody. So therefore they can be got rid of by the body, because ITP is an autoimmune disease. So that is something to think about. So if something comes along to trigger that immune reaction again and make it go over time, if you like, then something could happen. So I consider myself cured as far as I could be cured, but I still know that my platelets are covered in the antibody. And if something, as Adrian said, something like a virus or a vaccination or something that's going to challenge your immune system comes along and wakes it all up again, then your platelet count could drop. So, I mean, that's how I understand it. I hope that's correct.
Yeah, yes, basically correct. What I would say is that the immune reaction gradually wanes over the years. So the likelihood is after 10 years, if we looked at your platelets, we wouldn't find any platelet antibody on them. And for Glenn, I suspect that if cancer been normal, he may still have some antibody on them, but it would be very small now, because it's like the protection you get from vaccinations against infection. Years afterwards, you often lose that immunity, and you have to have your boosters. I mean, for some of things like flu or COVID, it's because the infection slightly changes character, but for a lot of them, the immunity gradually goes, and certainly a small number of people are cured from after splenectomy for two reasons. One, obviously the spleen isn't there to destroy them, but the spleen was also the site of the antibody production in the first place. The spleen is about a third of the immune system and is a very active producer of antibodies. So once you remove the spleen, then the propensity to produce antibody drops, but immunity wanes against things over time. And although it's quite possible that Glenn had a reaction to one of the statins, and clearly any drug can cause some immune reaction, it's a very small problem with the statins, purely because statins are so widely used in the country that there hasn't been a surge of ITP with the introduction of statins over the last 10 years. The incidence of ITP has remained very static over this period. So the introduction of a new drug means that if the ITP is related to that drug, it's a very, very weak and rare association. The fact that you responded well, if you need to go back on a statin, or there are actually other non-statin options, if your GP is still wary of that but wants to bring your cholesterol down, and it is worth exploring those as well. So Rhonda is right, but we have to take it with a slight caveat that immunity does wane, and in some people it's the spleen that produces the antibody. In other people, the antibody is produced in other places in the body as well as the spleen, and that's one of the reasons we don't take the spleen out in any great numbers. I mean, we've not taken a spleen out at Barts in London for quite a while now.
It was an option they discussed with me, but I decided to hang on to mine and see how the other options that they laid out might progress. So fortunately for me, it seemed to work out okay.
If the spleen's taken out without, I mean, we developed 15 odd years ago a test to look and see if the spleen was likely to be the cause of platelets being removed. And you do that by putting a very weak radioisotope onto platelets, injecting them back in and seeing where they're destroyed. And if you can show that the spleen is the only site where those platelets are taken up, then you know if you take the spleen out, about slightly over 90% will respond.
Right.
If it's shown to be taken up by other parts of the body, and particularly the liver and the lungs are main sites where there are other what we call macrophages, the cells that remove these platelets, then the disease will come back, and the chance of having any long-term response are probably 10-20% at most. If you take the spleen out without doing that test, the response is about 50%. So it's not something we recommend, because obviously if you have your spleen out and then you relapse, you're in a much worse position, because you're much more prone to infection, and you don't have the main organ of the body that helps you fight infection. So
my idea at the time was simplistically, if you take it out and it doesn't have the desired effect, you can't put it back again. So
absolutely, yeah.
Very helpful. Thank you.
Adrian, there are a couple of questions in the chat. One from Joe. They say, I had a blood clot and since found out I have factor 5 or factor V. I have to stay on blood thinners, which is problematic with keeping platelet count up. Should ITP people be tested for factor 5 and then warned about clots? I mistakenly thought ITP meant you won't clot, and wonder if the clot could have been prevented?
Now that's interesting. The condition she's talking about is something called factor V Leiden,
Okay.
which is one of two or three inherited conditions that are more prone to blood clots. Something called thrombophilia, which and depending on whether you inherit it from one parent or two parents, depends on what your likelihood to clot is. If you develop it from two parents, then you're very likely to have clots. If it's from one, it's less so. And depending on other circumstances in your history, the hematologist may want to give you anticoagulants. Now, that's a problem if you've got a low platelet count, in that we don't like to give some anticoagulants if the platelet count is certainly less than 30 and preferably less than 50. And if we do, we would tend to use something like heparin, which is quick acting and quickly reversed. The issue about ITP and clotting is a very interesting one, that you would automatically assume that if your platelet count is low, you don't clot. But in fact, there is a clotting risk with ITP for one or two reasons. One of the reasons is that the platelets that you have in ITP are young, fresh platelets, in that you're destroying platelets, therefore the bone marrow is trying to produce more. And these young, fresh platelets are more thrombogenic. They're much more likely to cause a clot than someone with normal blood. So we are a little bit wary, and we do check for a number of things when patients are reviewed at presentation as to whether they have a more likely cause of clot. One of the things we look at is something called antiphospholipid antibody, which is much more common than 5 Leiden, which is very uncommon. But the antiphospholipid antibody, or APL, is much more prone to causing clots, and in association with ITP has a highish risk. And it's certainly something that post-operation we get worried about. And for people, I mean, it's one of the big problems in patients having their spleen out, because when your spleen goes out, your platelet count whoosh up, and a small but significant proportion do develop clots after that, deep vein thromboses and pulmonary embolus, which can be highly risky. So there's a series of tests that most hematologists will do when someone presents with ITP, and it is looking at factors that may cause clotting. Factor V Leiden isn't generally one of them, to be honest.
Okay, thanks for that one, Adrian. I hope that answers the question, Joe.
But if not, come back if you've got more specific.
Yeah, please,
please come back,
come
or
back,
or drop us a line if
Now,
well,
there's another question, next question down from Zars. I think I pronounced that right. Do you want me to ask your questions, Zars, or are you doing a?
Yeah, please.
Yeah, okay, will do. She says, I had 2 tummy bugs and a cough and cold in November, which lasted 2 months. Would you recommend getting a platelet count because of her ITP? And also, they worry about foods that can affect the platelets. Now, this is one that comes up nearly every meeting, isn't it? About diet, etc., and all that. And you look at the different foods each time you go to the supermarket, looking at ingredients and hoping, wondering if something would affect the platelet count. Any recommendations, Adrian?
Yes, if you had the infections in November, it depends when it finished. If you've had nothing, if you've been fine for December and January, that's 2 months. And the likelihood is there's no point in having a special test now. And indeed, we try to discourage people from just having tests if there's no reason to have them, to be honest, because you get very wrapped up in what your platelet count is. And platelet counts vary all the time. And what we tend to say, and that's one of the reasons we're going against regular blood tests once the count has responded to initial treatment. If you have a problem and you have some bruising, have a blood count. If you don't have any bruising, you don't have a problem. If you need surgery, then they'll check it anyway. So it's an issue of if you've got it depends what your baseline platelet count is, but everyone gets a few bruises all the time, even with ITP if the count's low. I mean, specifically with ITP if the count's low. But if you suddenly have a change in your bruising pattern, you develop those little petechiae, which are the little red spots, particularly on the lower legs, or you suddenly get lots of spontaneous bruising, or you bump into a table walking into a room and suddenly get a big bruise there. That's unusual, and you need a platelet count. If you've got no specific change apart from the odd bruise, then there's no point. I mean, when you get a low platelet count after an infection is normally within 2 to 3 weeks. That's when the platelets react to the antibody that you're producing to the infection. We see a similar pattern in children who develop low platelet counts after infection, in measles, German measles, that sort of thing, that it's usually 2 to 3 weeks after the infection the count drops. And coming back to the point earlier about your immunity waning, as quite often for children who need no treatment, as the infection clears and the antibody clears in the blood, the platelet count comes up again. So the majority will respond spontaneously within 6 to 8 weeks after an infection. So you get the infection, count down at 2 weeks, 6 to 8 weeks, coming up again. And the issue with food is an interesting one. And to be honest, we know of no foods that regularly cause thrombocytopenia. Now, it may be that some of the additives, I mean, I read the book on ultra-processed foods, which I found quite alarming. I stopped eating 0% fat yogurt, which I thought was healthy when I read that book, because it actually, when the chemicals they put into it are atrocious and they don't know what they do to you. But we know of no chemicals that are regularly associated with an impact on platelet count. Now, the convention next year, which we're holding in June in London.
This year.
Sorry, this year. I've forgotten we've moved years. We've got someone who's talking about myths in ITP, and although I don't know exactly what he's going to talk about, although I will be discussing it with him, he's going to look at some of these questions potentially about infections and food additives and complementary medicines and things like that. But obviously that's an awful lot to cover in a short talk. But I mean, having said that, I remember many years ago, we had a patient a young lady who came in for a splenectomy, and on the morning of the operation, her platelet count was completely normal. And so we stopped the operation and she went out again and came back again very shortly after, and the platelet count had dropped. And we went through what she was eating, and it appears that she was reacting to the sesame seeds on McDonald's. And I mean, we didn't really want to challenge that, but she insisted and had a sesame, stopped, platelet count normal, took the McDonald's bun, and the platelet counts plummeted. So she was clearly reacting to something in the sesame seeds. So there are things, and I've had a patient who developed a very low platelet count having taking iodine supplements. So there are things that cause low platelet counts, just as we know drugs do. And there probably are food additives that we do, but there is no clear evidence of any specific ones that you have to avoid. And equally, there's no evidence that any particular food additives or any foods help your platelet count go up if you're eating a proper normal diet with lots of folic acid and vitamin B12 and vitamin C and things like that. Ron, did you want to make a comment? Mute.
Yes, I wanted to ask you what sorts of things you were trying to avoid. Yeah.
Well, things like, sesame seeds, tomatoes, tamarind, beetroot, and other things that affect them as well. So I was looking at each time we go shopping, looking at it. Oh, can't have that. Let's go get back.
But why did you think you couldn't have them?
Because I thought it would kill them by the thousands.
It was what? Sorry?
I thought you'd kill the platelets by the thousand. I thought, no, can't have that. It's...
Tomatoes and beetroot are good for you.
Well, what about sesame, tamarind, and I
Don't
can't
don't know
remember
about
that.
tamarind. Well, as I said, some people. I mean, again, it's a bit like statins. There are hundreds of thousands of people eat Big Macs, and there isn't an epidemic of low platelet counts. It's just this one particular girl, and there are probably almost certainly others who will react to it in that way. And it's only a question you can only find out for yourself by trial and error. But again, I suspect the vast majority of people don't.
Because for breakfast each morning, I try to have something with oats in it, like Oatabix or porridge, because I heard that can boost them as well. But
Well, as Adrian says, there's nothing that we know of that can boost it or lower it unless you have a particular individual, and remember the word individual, sensitivity to anything. So it's really, really important to have a balanced diet. And as Adrian says, if it's not a good idea to eat processed food. So if you're buying your raw vegetables, and, you know, if you're vegetarian, obviously you won't be having meat. But if you do eat meat, you would buy your raw meat and you would cook it. You wouldn't buy the meat already with a dressing or something on it, or some marinade or something that you're not really sure exactly what it is. So if you source your ingredients raw and then make them up, then you know exactly what you're having. So, I mean, all those things, all what I call ordinary foods that aren't exotic, like beetroot and tomato, you know, some people do have a reaction to tomato. So, you know, that would be one then that if you found that you did, then you would leave it out. But to cut out all of those really good fruits and vegetables and different things, you're reducing your ability to have a balanced diet, which is not a good idea.
So, in other words, then start cooking from scratch every day with little or no processed food, as you were just saying, and because you don't know what's in it.
That's right, and you could read that book, which I know I have heard something about it. It's quite alarming. But, you know, why would you eat processed food when you can eat really nice fresh food, which has got much better taste, and you know exactly what you're eating?
Because I try to eat sort of, fresh veg and fish and chicken and
yeah, that's brilliant. Brilliant.
Yeah.
Very good for you.
Okay, Linda, you had your hand up first. It's Linda and then Marvad. So, Linda?
Yeah, hi, hold on, please, sec. You may have already discussed this before, but I'm just checking with Adrian. I've had ITP since 2002, and I've been on all sorts of meds, and I was on M-plate, the maximum dose of M-plate. And then obviously COVID came along, and I got the COVID vax, and my ITP disappeared. My platelets went shooting up, and I was back to normal. And then after about a year, they started to dwindle. And then I got another COVID vax, they went back up. And then they started to dwindle after a year. Got another COVID vax, went back up. And then this year, I was hoping to get my COVID vax, well, last year, and my consultant won't give it to me because he said it's not research practice. So I'm not allowed to get a COVID vax. So I'm now on what's it called? Electrobag, the pill that you take every day.
Yeah.
So I'm now on that, which is annoying because I'd rather not take any medication and just have another COVID vax, unless the COVID vax are so bad that they're avoiding me having COVID vax, but my platelets are back down to 0. So it's like I've got nothing to lose if the COVID vax doesn't work. And I tried to go to my GP because I know the consultants at a hospital are lovely, but again, they're not 100% in tune with what ITP is. And I tried to get COVID vax through my GP, but it's actually on my notes not to give me the COVID vax. So I was just wondering, is that ridiculous, or is it? Can I just, I don't know what to do.
I mean, it's depressing, not ridiculous. When the COVID first came out, and there was a lot of worry about thrombocytopenia and COVID jabs, because it does cause it, but in a very small number. I mean, it's about 15 per million, and if you consider that normal ITP occurs in about 40 to 50 people per million, it's a small risk. And indeed, when we monitored it, and we got through the ITP Association, we got patients to let us know their counts before and after injections. And a significant portion of patients like you saw the count go up in the same way that some people post-infection see the count go up. Unfortunately, this year, the recommendations for COVID jabs is they're not given to normal adults. It's only people at risk from COVID or people of my age who get it for free. Someone of your age would have to pay for it if you wanted it, and then it's quite expensive. And this to me seems entirely stupid and completely illogical. We know the risk of COVID. We know how effective the COVID vaccine can be. You've shown yourself that you don't get an adverse reaction to it. And I wouldn't say the platelet count going up as an adverse reaction. And I think it's very depressing, to be honest, that you can't get it. I can't say anything more than that.
Yeah, I'm just annoying. So I'm back on meds again when I was like, I've been clear for the first time in since 2002. I'm back on meds rather than being clear of it.
It's a shame that your own hematologist doesn't recommend it to the GP. I can't see why, if you're on meds for your ITP,
I'm
then
back on electric.
Depending on what the meds are, that may well increase your risk from infection and would be a reason for giving you the COVID jab. I mean, that's a discussion you ought to have with your hematologist.
Linda, may I ask which hospital you're at?
Royal Berks.
Okay.
Berks.
Royal Berkshire Hospital, yeah.
Yeah, they're moderately experienced with ITP.
Yeah,
We've had dealings with them. Yeah.
I never see the same person twice. Well, I just see obviously Dr. Mucklow, but sadly he's gone. But never seen the same one twice.
Okay.
Just another quick random question. I'm going up to Everest Base Camp. Is it okay to take high altitude sickness tablets if I get altitude sickness when I'm on with ITP and on?
Yeah, it depends which altitude sickness. Well, I say it depends which, as I'm not aware of any of the altitude sickness ones that would be contraindicated. The ones, I don't know the trade names for them.
Dimoxide.
Yeah, dimoxide. There'll be no reason why you can't take dimoxide with it.
Thank you.
Okay, thank you very much, Linda. Marvad?
I just wanted to know if this ITP is genetic inherited, or is it just you just get it?
Again, as I've said with many of my questions, that's an interesting question. The reason you get it is because there's a genetic reason that you're developing an autoimmune problem, and autoimmune diseases tend to run in families. Not necessarily ITP. I mean, I actually once, a long while ago, looked after identical twins, each with ITP. Bizarrely, one spontaneously remitted and the other had her spleen taken out. I mean, this was 40 years ago, to be honest, where we took spleens out regularly. We see a very, very, very small instance of ITP in families, but it's by no means regular. But you do see other autoimmune diseases. So lupus, an ITP, autoimmune hemolysis, an ITP, diabetes, an ITP, thyroid disease, an ITP. There are associations with autoimmune disease. And so, which means there's some genetic basis for you developing this autoimmune problem, but it doesn't run in families in the way that we would classically think of that. So you don't have a genetic abnormality that causes ITP. You have a genetic instability that causes autoimmune disease that in some people causes ITP and in other people causes other problems.
Okay.
There's an interesting question. There's one or two more on the list. There's an interesting question about avatrombopag from David Bryan. Avatrombopag is associated with muscle weakness and fatigue in a small percentage of people. The cardiologists always used to deny it, but there's something called a proximal myopathy. Myopathy means muscle weakness problems, and proximal means your upper arms and your upper legs, to the degree that you can't comb your hair easily because your arms get too weak. Or in the case of a good friend of mine, he couldn't play golf because he couldn't swing the club anymore because his arms were too weak. Or you can't climb upstairs because your legs just won't do it. And you lower the dose or you stop it and it all recovers. So there is an association with avatrombopag and muscle weakness in a small percentage of people. So yes, it does. There's a clear association there.
Okay. Thanks for that one.
Sorry, this is David Bryan here. The question I actually wanted to ask was your thoughts on further reducing my dose. Like I'm taking a tablet every second day, and this is against the advice of my consultant. It's greatly improved my energy levels, but I've gone from not being able to walk to being able to walk. But I think like my levels are so good at 100, I wouldn't.
I mean, how long have you been taking avatrombopag for?
Since the start of January last year, so just for 13 months.
I mean, we published some while back sustained responses off thrombopoietins. It wasn't avatrombopag because that wasn't regularly used then, but it was in. We've seen this with L-trombopag and with romiplastin. And how we did that was, people would be on the full dose for a length of period, and if the count was normal, we'd start to tail it off. And by doing that, we sort of halve the dose. Then we'd give it alternate days. Then maybe give it every third day, and monitor the platelet count. A platelet count of 100 thou is very acceptable. I mean, a platelet count of 50 thou is very acceptable. So if you find that having reduced the dose like that, it's improved your symptoms, your problems, then there's no reason why you shouldn't continue like that, to be honest.
Yep. Okay, thank you.
Thank you very much, David. There's more questions.
And yes, ITP and immunotherapy for cancer.
Yeah.
I mean, immunotherapy is one of the well-recognized side effects of immunotherapy is immune thrombocytopenia. So the immunotherapy that's given for various cancers, I mean, that's how immunotherapy works. It disrupts your immune system. And if you disrupt the immune system, a small proportion of patients will develop antibodies against platelets. It's now very well recognized and described.
Okay.
I can't say too much about it, but it's if IVIG keeps the platelet count at a reasonable level, that's fine. In general, if you've stopped the immunotherapy, then the platelet count will eventually drift back up again. If you need to continue on the immunotherapy, then something like one of the thrombopoietins, avatrombopag, L-trombopag, or whatever, or IVIG will act perfectly reasonable. And it depends on what the cancer is and what the specific drug you're receiving is. But yes, immunotherapy for cancer is well recognized as a cause of immune thrombocytopenia.
Thank you for that, Adrian. The next question from Ian.
Tafasitamab.
Yeah.
Tafasitamab is a monoclonal antibody directed against something called CD19, which is a marker on lymphocytes. It's the same marker that rituximab attacks. It acts in a slightly different way, and it's a slightly different agent. And in the same way that some patients respond to romiplastin when they haven't responded to L-trombopag, or the other way around, patients who've received rituximab and haven't responded or lost the response, then the company that produces tafasitamab are now doing what we call a phase 2 study to see if it works. And a phase 2 study is essentially a study to see what the degree of response is and what the side effects are in a proportion of patients. So it's an early study to see whether it works and whether the problems are, yeah.
Right.
That's, I presume.
Did you just share that, Mark?
So someone has, well, that shows, well, whatever that shows, it shows the platelet counts came up very quickly with the prednisone. As prednisone drops, you sometimes see a little dip, which you often do when the count comes down, and then the platelet counts have gone up again. Fantastic result from 2025.
Yeah. Up till
January. Oh,
January this year. Yeah. Okay.
That's good. Yeah. So it's a good study. They're doing studies in both immune thrombocytopenia and autoimmune hemolytic anemia. as well to see the response of both, to see what the response of both is.
Okay.
These sort of drugs that act on the immune system work in a number of conditions. They work in lupus, they work in haemophilia who've developed antibodies, because what they do is they knock out the lymphocytes in the body, which are the lymphocytes that produce antibody. And they seem to have a particularly differential effect on abnormal antibodies, but only have a mild effect on the body's normal antibody response to infection, which is good. I mean, we've seen that with rituximab over the years. I mean, a small number of patients with rituximab, again, will develop what we would call immune deficiency, will become very prone to infections, but the vast majority don't. It just impacts on the autoantibodies, which is good.
Okay, the next question we got is from Sue Wheel. Sue, would you like me to read it out for you? Yeah, okay, yeah. Well, again, it's avatrombopag. Sue says she had severe dermatitis for 10 months on avatrombopag. Reducing to alternative days has reduced the dermatitis a little. She's had lots of steroid creams, skin biopsies, dermatology and hematology agreed it's drug induced.
Yeah.
Have you seen any other patients reacting this way? She starts on rituximab next month.
I haven't personally seen that, and it's not something that we commonly see. But again, and also the problem with avatrombopag is a relatively new drug, being used widely now for the last year to 18 months. And of course, when you do initial studies, because you're actually looking at small numbers, you don't actually pick up some of the very rare side effects. It's when you start using them on a much wider basis that things like this come through. It's not something that's widely recognized, but certainly something that happens, and it is for you an unfortunate side effect of,
because it's just the same as I had on romiplostin.
Is it? Yeah.
I went to fostamatinib, which I didn't get on with, but
yeah. Many patients don't get on with fostamatinib, but again, it's probably an impact of what we call the family of thrombopoietins. So romiplostin, probably eltrombopag as well, if you had an avatrombopag.
Yeah, nosebleeds with that.
It's a sort of immune reaction that's causing your dermatitis, that they generally respond to steroids eventually, but they only respond better when you stop the drug, to be honest, which is obviously what they're trying to do.
They're going to try, and we'll see what I do with rituximab.
See how it goes, yes.
Thank you, Sue. Thank you. Got one here from Catherine, and again, it's on we was talking about blood tests earlier, and trying to discourage regular blood tests. But Catherine's saying, I understand that general practice is to discourage regular blood tests. However, when living with chronic ITP, how can you make lifestyle decisions without knowing what your levels are? For instance, her son, who is 16, has been told not to do gymnastics or trampoline, and his platelets tend to be between 20 and 50. He would dearly love to be able to resume his activities, and I get the impression he would be allowed if he was closer to 100. How do I know they have risen or have plummeted since? His normal symptoms don't always match his blood results.
The advice not to have regular blood tests or blood tests unnecessarily is essentially normal people like you and I, who, well, maybe me, who doesn't do anything more energetic than a spot of golf, and I've not been hit by a golf ball yet, so I'm safe from that point of view. But if you want to do something that's challenging, I mean, I looked after a professional footballer a while back, and I have to say we would certainly check his count, particularly if you're a midfield enforcer. You need to have a pretty good platelet count, otherwise you bruise alarmingly. So again, if you've got someone who wants to do active sport, and this is a particular thing in children, you do want to know that the count is safe for them. And a count of less than 50 is not safe for someone who wants to trampoline, to be honest. A platelet count of probably greater than 80 and certainly 100 is. I mean, we reckon we're happy with a platelet count of greater than 80 for really the finest, delicate surgery on the brain or the back or whatever, because you don't have a bleeding problem then. But a count less than 50, I would be very worried if someone was doing something that was likely to impact on damage of playing rugby. trampolining in those sort of things, to be honest. And of course, for those, you do want to know what the platelet count is. So the advice that I'm about not wanting to have regular counts is just for a normal person who has no bruising, no problems. A count every 3 months doesn't take into account the fact that after a month after that, your platelet count may fall. If you have an infection, it's far better to have a regular association with your hospital or your GP. So if you have any worries, you just phone up, pop up, have a blood test, and get it done as and when you need it, not on a just a calendar basis.
Okay, thanks for that. And Lauren was also interested in that as well, because she said like Catherine that the symptoms don't always match the blood count, which is true. But yeah. So okay, next question.
Well, there's one on cataracts.
Is there? Okay.
Which is sort of between those two.
Okay.
It depends. How old's your daughter? It's Samsung SM. Because I mean, cataracts are common as you get older. I assume your daughter isn't my sort of age. I mean, you often develop cataracts as you get older. They are caused by certain drugs. I mean, steroids, prednisolone, are well associated with the development of cataracts long term, as are conditions where steroids are abnormal. So they can be associated. We did, when L-Trombopag was started, there was a potential risk of the development of L-Trombopag and cataracts, and all the early patients with L-Trombopag had to have regular eye checks to see if they were developing cataracts, and it didn't turn out to be any significant problem at all. But again, there could be a link, or it could just be age. It could be related to smoking. It could whatever. I mean, there are various lifestyle things associated with cataracts. You always have to be wary of anything you're taking if you develop an unusual problem. Cataracts are not unusual, to be honest, and whether you continue on the drug depends on clinical need. And if you respond to the drug and want to keep on it, then it would be important then to say every 6 months to have their eyes checked to have cataracts. And if they develop, then you probably need to reverse it, although it may not stop the drug, although it may not be related to that. But it's just a risk that you wouldn't continue. But it's a question of sort of careful monitoring if you need that drug. If you don't need that drug, or there's an alternative, then you can change it. But cataracts are common. Cataracts often don't develop. They're there in the background. Many people will have a mild cataract and not know it. I have a mild cataract when I have eye testers, but it's never caused me any problem. And I was quite surprised when they told me I'd got one, because my eyesight hadn't changed at all. So
I had two. So yeah. They're both done. So yeah.
I mean, I think if someone's born with a cataract, then they tend to be slightly severer rather than the sort of mild ones that I'm talking about that develop as you age.
Okay.
Hello, sorry, it was myself that submitted the question, but
hi.
I can't get my camera on because I'm on my phone, so sorry. But my daughter is 12 years old, but she was diagnosed about 4 years ago for ITP.
Well, it is unusual to develop cataracts at that age if you haven't maybe developed them earlier in life. It depends how long she's been taking romiplostin for. I think cataracts are less associated with people who are taking romiplostin with the L-Trombopag. I don't know about avatrombopag, I have to be honest. So I would suspect
she did have the L-Trombopag first, actually, but it didn't work. And then she had the rituximab, which we weren't sure if that worked. But then she did actually start the romiplostin almost straight away after the rituximab. So her hematologist wasn't sure if it was the rituximab that kicked in or whether it was the romiplostin. But then she had the romiplostin for about 18 months and then came right down to the lowest dose. The platelets were around 100. So she's not had any treatment for 18 months, and they've slowly started to drop again. They was in the 20s around Christmas time. She had her bloods done again yesterday. They've gone up to about 43. But she's really wary about starting the romiflozin again due to because she has been seen to have got really small cataracts.
I mean, I can understand her reluctance. It's unlikely to be related to the eltrombopag because the worries about eltrombopag were people on it long term. So a short course that didn't respond is unlikely to cause it. Rituximab is unlikely to be associated with it. As I said, romiplostin may, but it's a very rare association. But again, if she's worried about that and the potential alternatives, then leave it. What I would suggest is that it's probably better just to monitor it. If the last count was 43, if it's above 20 and 43, there's no indication for treatment. And I think it's best to monitor both the platelets and periodically the cataracts to see if they're residual small ones there that don't develop or whether they are developing. And if they're developing, that's more likely to be a congenital thing. By that I mean it's part of her own body.
Okay.
Okay, thank you.
Thank you very much. Right, the next question, Adrian, interesting one. I've been stopped avatrombopag due to the cost and put on eltrombopag. I'm assuming this is the generic version now.
Yeah.
Yeah, due to the cost. It's the same all over the country, or is it just my hospital? It's not nice due to dairy restrictions, and now I've had to go on mycophenolate as well. So far, I've not been feeling so well. I seem to be okay when I was on Ava. This is generally, isn't it, now with the move across from
yeah, I mean, I'm to be honest, again, I'm surprised they stopped the AVA. They just for those of you who don't know, there's eltrombopag has come off patent, and a generic product has come through that costs, I wouldn't say pence as opposed to hundreds of pounds, but it's much cheaper. But one of the caveats is that people who've responded to the drug they're on, they don't normally change them, or if they do change them, there's a problem. They put them back on the drug that they were on, and obviously, one of the advantages of avatrombopag over eltrombopag is that there aren't the dietary restrictions, and they are relatively symptom-free. Mycophenolate does cause symptoms, and it's quite effective. It's not as effective as the thrombopoietins, to be honest, but it does respond for people, but they do have more side effects. So again, I think it's disappointing that they stopped avatrombopag when it clearly worked, and you've now had disruption. And again, it's something to talk to the doctor about and say, look, this worked. I've now had all these problems since you stopped it. Why can't I go back on it and just pin them down to that?
Joe, can I ask which hospital you're at? If you just put it in the chat, that'd be okay. Okay, thank you. Right, moving on to the next question. Susan Briggs. This group suggested I move to avatrombopag from eltrombopag, so I did. I have dietary restrictions. It's been brilliant, and the dose I need is a lot lower than on eltrombopag, so the cost difference doesn't matter. I was an identical twin who did not have ITP. Right.
Yes.
Sorry, I'm not really asking questions. I'm just commenting on what I hear.
Yeah.
No.
Good. That's good. Interesting, but interesting about the twin part as well.
Yeah.
I would say that the identical twins I mentioned, the only time I've seen identical twins with ITP in my entire career.
All right. Okay,
I have seen the odd case within families, but again, it's as I said, autoimmune disease does occur in families.
Yeah.
Slightly more common in women up to about the age of 60. After 60, it's more common in men because their men's immune systems tend to wear out more quickly than women's.
Okay.
I was very grateful to this group for suggesting avatrombopag because I'm a vegetarian. The dietary restrictions in our trombopag were difficult to cope with.
Yeah, yeah.
So it's worked better than the
good.
And that's a very valid reason for being on one drug rather than opposed to another. Yeah.
And for the person who's reducing, I mean, they moved me to that, and now I'm just onto one every 5 days, and they're looking at taking it even lower. So it's been very effective, and I've had ITP for 50 years. So
okay.
You know, so it's worked well for me.
Thank you, Susan. Thank you. Right, Gabby. Question: I have type 1 diabetes. My daughter is now 2.5 years old, or is that 25? She had lots of bruising last year and has been diagnosed since March. She's reacted well to steroids and IVIG, but her platelets always drop. We're about to start our trombopag. I'm concerned as she is still so young, so she is 2.5. Is there anything else you could suggest? And she's still waiting for the genetics results. So
yeah, well, to be honest, I mean, it's very unfortunate for someone of that age to have ITP, and only about 20% of children of that age with ITP develop a more chronic sort of condition. We do know, and this is work that we sponsored through the ITP Association that was developed by our paediatric registry in Manchester, that the effectiveness of drugs like eltrombopag and romiflozin in youngsters with ITP, and it's certainly probably the best one to take. Those options are the best ones to take for kids of that age and are least likely to have side effects.
okay.
I mean, obviously the genetic results are important, but they take a while to come through.
Well, yeah. I'm conscious of the time now, so just going through.
Oh gosh, yes.
Yeah. Next one down. How can someone protect their liver and other organs from the effects of a medication like mycophenolate?
Stop drinking.
Stop drinking.
It's the only way you can protect your liver.
Okay.
I mean, that's a bit facetious, but there.
Yeah. I know exactly what you're saying. I've been told the same. Right. Okay. Rachel, I'm new to ITP. My 19-year-old son was born 28 weeks premature with platelets at 45. And
hypogammaglobulinemia. So
yeah, I'm glad you can pronounce that. I can't. Yeah. I had pneumonia at 18 months and his platelets went down to 8, had IVIG and they picked up to 21 to 28 as his norm. Following COVID, he went down to 7 and was given steroids, which didn't help. And now just diagnosed with ITP, has been taking avatrombopag 20 milligrams since 16th of December. Count was 10 on the 30th, so up to 40, and then it goes on. So
yeah, I mean, if he was diagnosed at that age with a low platelet count and hypogammaglobulinemia, that means he's got some immune deficiency syndrome. Common variable immune deficiency is the commonest one, but I guess there are others, and I guess he'll be looked after by a specialist pediatric unit. We do tend to treat the low platelet count if there's a risk of bruising, and again, the drugs like avatrombopag are important because they're not immune suppressant, whereas giving someone with hypogammaglobulinemia steroids over a long period increases the infection risk and is not really recommended. But it's a very careful decision that has to be made by a specialist pediatric unit who have experience of these conditions. So this isn't straightforward ITP. This is congenital immune deficiency, which is well known to be associated with autoimmune conditions, of which ITP is one of them.
Okay, thank you. Ian has asked a question. Any thoughts regarding stress and ITP? Now, this has come up a number of times when we've had psychologists involved as well on the various things. Any views on that, Adrian?
Well, I mean, stress causes a lot of immune sort of hormonal imbalances that may be associated with the platelets fluctuating. It won't cause ITP. It could impact on your response to treatment and generally how you're feeling and how you're coping with it. But I think it's the ITP itself causes stress. Anyone with a chronic disease will develop stress, can develop stress because of the uncertainty of what your platelet count is doing, what treatment you're going to need, whether it's going to suddenly cause you a problem, can be really very unsettling.
Okay.
I don't have anything more to say with that. We did have 3 very good Zoom meetings with a psychologist earlier in the middle of last year, and we're hoping to have probably one more this year, so maybe 1 a year. And the guy has wonderful suggestions about sort of things you can do to try and counteract stress.
And those meetings are actually on our YouTube channel as well.
Yeah, yes, actually, I forgot that.
You can go back to that. But what I would add to that as well, I was at a meeting in Cardiff with the Cardiff University haematology team earlier in the week, and it was a pleasure to they actually brought down their clinical psychology team to actually speak to all the patients as well. And they had some great tips as well about, how to manage stress, etc., and all that. And more haematology teams are actually going down this path as well, even though there's very little budget for it. They're trying to, bring it into their workplace, which is good.
Yeah, we have there is a group that many of you not be aware of called the Clinical ITP Forum, which is a group of the majority of hospitals around the country that treat ITP. We get together and we have 2 to 3 meetings a year, one in person at the British Society of Haematology meeting, and then meetings online. And we also have a website where we discuss difficult cases. And one of the things we have been discussing is the issue of psychological support and how we can provide it. Now, no unit looking after ITP could sustain having a psychologist full time, but we're looking at having a psychologist in conjunction with other conditions, so haemophilia in particular, so we can maybe share some sessions of a psychologist to help support patients with ITP, because I think it is crucial. It's not just a condition you've got, you take a tablet and that's it. It has major impacts on your body, your lifestyle, your mindfulness, all sorts of issues like that. Rhonda writes about things like that, how to relax regularly in our Platelet magazine, and has some great thoughts about things to do, but it's in the few minutes I've got, I can't talk about it any detail, but it is
yeah. Just wanted to say, because I'm conscious of the time here, it's not just a psychological stress, it's like physical stress. So if I've decided, right, it's time to go get fitter, and I've started hitting the gym more, or I've been working long shifts, doing a lot of work. So it's not just the psychological side, it's what's your thought on the physical side as well.
Fatigue level,
etc.
Yeah. Well, the fatigue level can be very, very high, but what Adrian mentioned there, Professor Adrian Morgan did some great talks on the spoon theory, which is how you cope with the physical fatigue, etc., the ITP can bring, and how you manage your workload and your day and that. So, Adrian, you want to add to that? Because
yes, we surveyed this amongst ITP our members a long time ago, and about a third of patients with ITP have quite severe fatigue. Again, at least another third have an impact of fatigue, not severe, but their background, and a third don't have it at all. And it is something that we have been very interested in. Right. Some patients, when the count goes up, the fatigue goes away, but not in everybody, for a variety of reasons, which I can't go into now because we don't have the time. But yes, it does impact on your bodily well-being and how you cope. And it's difficult to exercise through it, to be honest. It's a question of tailoring the exercise that you can do compatible with what you feel capable of doing, and then maybe slowly trying to build it up to see if that helps.
I've had good numbers for years, like at the Foston-Matinib. I was more than happy, but every time I've pushed myself, suddenly my platelets drop. So it's not having the fatigue when my platelets are low, so I understand that. It's when I've been in remission and then I've pushed myself, then my platelets snap.
Yeah,
to me. So it's
interesting.
One of the issues relating to that, again, without going into detail, even when the platelet count's normal, a lot of patients with ITP are still destroying their platelets. So you've got what we call a compensated thrombocytopenia. You're producing as many as you're destroying, but that immune destruction in the body releases what we call cytokines, chemicals within the blood that are associated with fatigue. So even though you may have a normal platelet count, you can still be fatigued because you've still got the background impact of platelet destruction.
Yeah.
Okay, thank you, Ian.
Okay.
Thank you.
No, thank you very much. Cheers.
Thank you.
Great, thank you. Right.
Just one last answer about the flu jab.
Go on.
The flu jab is associated with thrombocytopenia in very small numbers. It usually responds either spontaneously or to a short dose of steroids. Drugs like quinine can cause thrombocytopenia, so certainly if you've had it, you shouldn't take it. Ibuprofen can affect how your platelets work, but they don't tend to knock the platelet counts down, but they can increase the bleeding at any level of platelet count. Certainly, a count that comes down after a flu jab is drug-induced ITP. It may not happen if you have another flu jab. It's idiosyncratic. We certainly saw that with COVID as well, and it's well described in other conditions that just because you had it once doesn't mean to say it'll happen the second time.
Okay. Well, I think that's it for this meeting. Thank you very much, Professor.
That's a great array of questions today. Actually, we covered a lot of areas.
Number of questions.
Really, really interesting.
Yeah. And just for everyone's information, the next virtual meeting will be the Scotland meeting on the 24th of Feb. As always, anyone can register and take part in that. That will be with Dr. Catherine Baggott. Then looking ahead to June, Adrian's already mentioned it. We've got our annual patient conference convention at the Royal College of Pathologists on the 27th of June. Got a fantastic array of speakers there. There'll be lots to discuss, some really interesting stuff. Come along, you get lunch. The tickets are very, very reasonable. We have subsidised them greatly. I know it's in London, but that's the area where most people can actually get to quickly. So please come along, register on Eventbrite if you want tickets. But thank you again for your company this evening. It's been a really interesting meeting, one of the really good ones. They've all been good. This is one of the really exceptional ones.
And I'll just add a point in after Mervyn. We haven't been able to deal with all the questions. Some of the comments here may provoke thoughts and questions you've got. Feel free to write into the association and we'll get either myself or one of our other medical advisors will respond to you. So we're happy to do that. And I'll just reiterate Mervyn's comments that this has been a really great meeting. We've covered a lot of areas with some really interesting questions.
Thank you very much, everyone.
And I hope it's helped you. Thank you.
Take care. Thank you. Bye.
Thank you. Bye. Bye.
Bye.
Bye.